Hello to those just joining. We're going to give it a few minutes for people to log on. For those coming on, we're just going to give a minute for some more to join. I'll give it one more minute. Well, hello, those that are joining, and there'll be a few more to come in, but my name is Dr. Paige Harrington. I work with Vets Pets as the Vice President of Medical Leadership, and we have been doing these last Tuesday of the month CEs for a couple years now. Welcome to our first one for 2024. We really aim to give practical CE for you guys that are going to work tomorrow, some knowledge that you can actually use in practice at the start of your day tomorrow. And I really would like to thank Dr. Robert Brady for always being willing to join us for these talks and giving us his surgical knowledge so that we can go to our practice the next day and actually utilize it in our own practice. He's going to be presenting tonight. I have a down dog, now what? And as we go through, if you have any questions, everyone's microphones are off, but go ahead and enter into the chat. And I will either interrupt Dr. Brady, right away and ask him a question, or I'll just wait until there's a natural break in the talk to go ahead and answer those questions. So I'll be the one saying, hey, Dr. Brady, we have a question, and then he will clarify for you guys. After the CE tonight, in the next week, you will be going ahead and getting your CE certificate in your email inbox, and also a link to a YouTube video of tonight's talk. So yes, take some notes, but you will actually be able to click on it and watch it again. If there's anything here that you think, what did he say about that again? I just want to look that up one more time. So Dr. Brady, thank you so much for joining us here this evening, and I will let you take it away.
Thank you, Dr. Harrington, and thank you everyone for showing up this evening again. We are going to talk about what happens when you have a down dog come into your practice, and we will. So a little about me. I went to East Carolina for undergrad and master's, and down to St. George's for vet school, then rotating internship down in Charlotte, and then Memphis veterinary specialist in Memphis, Tennessee for my residency. I'm currently, for just another couple of days, the primary surgeon at Points Easton Wilson, but we are very excited to be welcoming Dr. Brenda Austin starting next month with us to hopefully further the amount of patients that we can help in Eastern Carolina. And a little bit deeper, I'm from Tarboro. I'm married to Abigail Brady, who's a ER doctor at Points East as well. Got a bunch of youngins at this point, 5-year-old Deacon and 2-year-old Emerson, 7-month-old Owen, and lots of small creatures on our little hobby farm with goats and chickens and Anatolians and such. So without further ado, we'll kind of get into a couple of questions to see, what our population is like. The first one being, have you ever treated a down dog? We'll give you a couple of seconds to answer that. All right, let's see. Get our results. It looks like 85% of y'all have treated a down dog. So hopefully a lot of this information is hopefully useful for you, and maybe learn a tip or two. All right, next. Have any of you owned or adopted a down dog? Hopefully return to function, but have any of you had a firsthand experience, managing one of these little creatures? All right. Okay, so it looks like 6%. So two of y'all have personally dealt with this. So, I'd be happy to hear your firsthand experience sometime if you have a chance to catch up with me. I've never personally managed a down dog either outside of their time in the hospital. So, that comes into tonight's topic of, when we have a down dog, how do we approach it, and how do I like to think of it in a clinically relevant way to help this animal the best. By far and away, the discussion is going to be kind of catered towards our small down dog, a dachshund, a shih tzu, very, very common breeds. There are some things to consider for larger dogs, but the purpose of this talk is going to be more about that the common thing that we see, that down dachshund that comes in. But if you have specific questions, I'm happy to take note of those and see if I can answer them for you. But really, as with so many things, when we decide how we're going to treat something, I like to kind of keep it basic. First and foremost, the goals of diagnosing and treating the dog are lesion localization and severity, because that's going to be the most important thing for being able to provide a pretty accurate prognosis for these guys. Differentials, because not every down dog that comes in is going to be a disc herniation. Most will, but not everyone. So we'll kind of breeze over a few of those differentials, but again, focusing on the acute disc herniation pets. Does this animal need imaging plus or minus surgery? And then, a treatment plan for that animal, whether it's conservative therapy, whether it's how to set up the referral, or kind of taking that next step once you have your pretty accurate diagnosis from there. So now another question for you guys: what is the most common lesion localization for the down dog? We'll get into our sections of lesion localization again as we get into the talk, but before we get to cheat, where are most of these animals going to localize to? All right, so the vast majority of you said T3L3, and you would be correct. By far and away, most dogs with an acute traumatic disc herniation will localize to T3L3. So lesion localization, again, this is just a reminder of our segments of the brain and spinal cord. So, of course, we have the brain, which would be our, not something I deal with too much as a surgeon. If we have brain pain, maybe get that neurologist involved. But most common localizations that we do deal with surgically are, the C1 to C5, C6, T2, T3, L3, L4, and you might see S1, S2, S3. It's all more or less the same thing. So those are our broad categories of lesion localizations as we go through. Another thing to talk about are some, basic nomenclature as we get into describing down dogs and being able to communicate efficiently, so that we're not, using a lot of redundancies or, trying to figure out what's what. Basic nomenclature here, our paraparetics are going to be the most common. That means that weakness in both hind limbs. One big differential there is, are they ambulatory, meaning can they still walk, or are they non-ambulatory, meaning that they can't? Plegic means absent motor, so there's really no need to talk about ambulation. If you tell me an animal's plegic, I know they're not using those legs at all. Tetra meaning all four limbs, whether it's paresis or plegia. Hemi being one side, so hemiparetic, hemiplegic. And then mono meaning single limb. So again, by far and away, most animals that present to us that are having some amount of neurologic dysfunction will be the paraparetics or the paraplegics. but we do have our fair share of cervical discs that end up being tetraparetic or tetraplegic. It's exceedingly rare to have the hemis and the monos, and generally those are less surgical in nature. Again, a brief overview of our upper motor neuron versus lower motor neuron pathologies. So remember, our upper motor neuron diseases normally involve spastic, tight, a lot of muscle tone. Lower motor neuron is typically more flaccid, loose. So as we get into our lesion localization, here's a nice summary graph of, we have an animal, for example, with a C1, C5 lesion, then we know that all of those inhibitory neurons, or most or a lot of those inhibitory neurons, are being blocked by the compression or the tumor or what have you. So without inhibition, we see those upper motor neuron signs. So we'll have spastic reflexes in the thoracic limbs and spastic reflexes in the pelvic limbs. Whereas when we have the lesions at the thoracic and lumbar intumescences, so C6T2 and L4S1, again, nomenclature for, L4S1, L4S2, variable depending on your source, we actually start seeing some of those lower motor neuron signs. So an animal that has a C6T2 lesion will often have flaccid thoracic limbs, weak withdrawal, weak reflexes, whereas, everything caudal to that will have upper motor neuron reflexes or normal. So their patellar reflex will be exaggerated, but their front leg withdrawal will be weak or absent. So remembering your upper motor neuron versus your lower motor neuron will help you as we start working on, lesion localization. Another thing in terms of, how severe things are is based off of the anatomy of the spinal cord, the order of loss of neurologic function, first to last. So one of the most sensitive tests we have is simple proprioceptive positioning. So flipping their little paw over and seeing if they correct it. The first thing that's going to go if there's impingement on the spinal cord will be that proprioception, followed by motor, followed by continence, followed by superficial pain and deep pain. So this also means that if an animal has these clinical signs and they, either get medical management or surgery, we expect for them to come back in the opposite order. So, the first thing that we may get back in an animal that's deep pain negative is pain sensation. Then hopefully they regain some continence and then motor and then proprioception, and ultimately the goal of them being, ambulatory again. So, again, here we can increase our efficiency of discussion by knowing that, if you tell me an animal has motor, I know they automatically have pain sensation. So if an animal has motor, it's not really necessary to go squeezing their toes. So, keep that in mind as we think about the order of loss of neurologic function. And when we do our neurologic exam, what components may or may not be necessary, as well as patient comfort. Again, if they're moving their hind legs, no need to squeeze them with hemostats because we know they can feel them. So the way I approach localizing the lesion starts with, like most everything, a bit of a hands-off exam. Looking at their mentation, a brief cursory look at their cranial nerves. Are they tracking you across the room? Are they looking around? Are their pupils equal in size? Just that basic, is this animal normal in the cranium there? If it is normal, then let's keep on trucking and talking about next steps. However, if you find that their mentation is abnormal, their cranial nerves are abnormal, then again, maybe considering a neurologic consult for some kind of intracranial lesion may be best for those animals. But again, typically our standard down dachshund is going to have a very normal mentation and cranial nerves. The next thing I look at for them is, are they ambulatory? So are they dragging themselves across the floor as they're, looking at me, or am I slinging them around? Are they able to support their weight? Are they able to move themselves on their own with their pelvic limbs? So is this animal ambulatory? And that's a simple yes or no. Along with the ambulation status is motor. Are they able to move those legs? So clearly, if they're ambulatory, they have motor. But let's say they're not ambulatory, it is important to differentiate if motor is present. So are they trying to place their leg a little bit? Are they kicking their leg a little bit? And again, it does take a bit of a keen eye as we're looking at them to differentiate purposeful movement versus, oh, their toe just kind of got caught on a bump on a rug and then it popped forward a little bit. So, very careful visual observation for is motor present or not. So once we got through our, overall, just more or less looking at them, then we get into our palpations and spinal reflexes. And then very lastly, if necessary, we get into pain sensation. So again, if this animal's ambulatory, I don't need to pinch their toes. I still need to do my palpation and my spinal reflexes to see if they have excitable patellar reflex or if they have flaccid pelvic limbs. Do they have anal tone? Those kinds of things. But I'm not going to go pinching the toes of an animal that has motor. So keeping those things in mind again, so we can keep our exams efficient, as well as not do unnecessary stress to a pet that's probably already pretty stressed out. So now, when it comes to reflexes, what is the most reliable spinal reflex in the dog? Meaning you can trust it the most. Is the patellar the most reliable? Is the sciatic, radial, withdrawal, or you can't trust any of them? All right, so we're pretty widespread across the board here. We got one jokester in the group that said you can't trust any of them. I like you. But then otherwise we're pretty drawn out. But in the reality, the most reliable spinal reflex in the dog is actually the patellar reflex. So the patellar reflex is the most reliable, and really the things like the sciatic and radial are very commonly useless. Withdrawal is quite important, especially in the thoracic limb. It is um, the most meaningful in the thoracic limb, but overall the most reliable is going to be your patellar reflex. So what is a spinal reflex? Remember, a spinal reflex is simply a transmission of a signal to the spinal cord and then back down to the muscles. So it does not go up to the brain. So a spinal reflex, has nothing to do with pain sensation or conscious thought process. That little reflex arc directly goes from whatever the question is, say the patellar tendon in this instance, up to the dorsal root ganglion, into the spinal cord, synapse into gray matter, and then straight back down to the muscle. So, there is no thought involved. There is no tracking, cranial up the spinal cord involved. It's straight to the spinal cord and back. So things to really remember that are really important are those muscle spindles and those Golgi tendon organs. So critically important to make sure we keep those massaged. And of course, I'm joking if anybody was curious on that. So patellar reflexes, as the diagram shows, tap the patellar tendon. It does indeed utilize the Golgi tendon organ and muscle spindles, but not really important for the clinical setting, up to the spinal cord, and then back down to the quadriceps muscle where it will create that slight contraction as a protective mechanism. So we have a lot of information now. So now that we have our, basic, neurologic exam and lesion localization well on our way, what do we do next? So overall, my approach again is when the animal comes in, starting head to tail. So we've gotten through the initial, cursory view. So now we need to get into some of the more specifics of spinal palpation and reflexes and things of that nature. So as we transition from our broad overview to some more specifics, I do see there's a, maybe a question in the chat. Um, or nope, somebody just typed the number 4. So, but if you do have any questions about anything, don't hesitate to add that to the chat function. So my approach generally is start to the head to tail, very similar to my just normal physical exam. Generally, it involves starting with a supported exam because remember, this animal is down, so they'll probably need some support under the belly or a sling. Once I've done the supported exam, then we'll slide into the recumbent portion. So, by far and away, the topic of discussion are paraparetic and paraplegic pets. And so knowing that, we can, kind of breeze through the cranial half of the exam because generally, if their thoracic limbs are normal and their brain is normal, then those reflexes and things will be normal as well. So we can try to increase our efficiency of our exam and focus on the more clinically relevant things as we go through that neurologic exam. So in the beginning, I like to, of course, gently comfort the pet. As we're looking at them, we're tracking their eyes, are they moving their ears? Just a very brief, abbreviated, cranial nerve exam. Can they hear you? Are their face symmetric? Nothing too invasive at that point. So once we get through this, the physical observations there, I like to move into the range of motion of the cervical spine. So flexion and extension, all the way to the right, all the way to the left. And if they have any pain, that's an important note there. And generally, if they're going to have pain in their neck, it's probably going to be a tetraparetic or tetraplegic animal. So if it's a, paraparetic or paraplegic, then I wouldn't expect pain on that range of motion. Then we slide over to the proprioception of the thoracic limbs. So, that paw reflex test. Our smaller animals, we can even support completely and touch the tops of their toes to the desk and see if they try to step up onto the desk, or just simply supporting them. And the trick is making sure they're bearing some of their weight, especially on their thoracic limbs, so that their body triggers them appropriately to correct that paw position. Again, most of these animals that we're describing will be normal to this point. But as we start moving more caudal, we'll have to start, working on really paying close attention. So after we've gotten to the thoracic limbs and that standing portion, I'll then move on to spinal palpation. So, firm, but not cranking. If these animals are actually painful, it's not going to take a lot of effort to elicit a pain response. So that also means that you need to proceed with caution because naturally, if an animal is painful, maybe they react in an aggressive way or whip around or something. So, just firm pressure as you palpate, down the thoracic spine and down to the lumbar spine, and just be prepared to, pull your arm away quickly, if we do hit a very painful spot for them. Pain is generally elicited near the site of the injury. So, as you can imagine, when they have this supposed, disc herniation as our main differential at this point, there is a vast amount of inflammation, around that surgical site. So a pretty intense pain response can be elicited near the site of that localization. So now that we're done with our spinal palpation, we like to move on to the tail, checking for tail tone, anal tone, painal manipulation of the tail, a tail jack, if you will, see if they have any lumbosacral pain, see if there's any discomfort there. So now that we've done our full supported exam, we'll now move into the recumbent exam, where essentially we'll have the patient in lateral recumbency. It doesn't matter if it's right or left initially, and then we'll start working on some of our spinal palpation, or spinal nerve reflexes. The thoracic limb, again, not really, a lot, the radial and the triceps and extensor carpi radialis, etc., not the most useful in general. And again, if their thoracic limbs are otherwise normal, we don't need to put a lot of stock into trying to elicit those responses. But again, if you're going to do anything in the thoracic limb, be sure to do the withdrawal because it is the most useful of the thoracic limb reflexes. Now, as we get into the pelvic limb, we need to really focus on the patellar and the withdrawal, but we can also do cranial tibialis and sciatic. So, and then finally, as they're lying, I'll go to my cutaneous trunci. Cutaneous trunci is really an interesting reflex. It comes from the lateral thoracic nerve that originates at around the level of T1, T2, and tracks caudally. It's responsible for the pedunculus, or that shaking, like when an animal has a fly on them, for example. And so when we do the cutaneous trunci reflex, we start at the ilial wing because, again, we don't want to do things repeatedly. And if we were to start up around the ribs, then we have to pinch there and then farther back and further back and further back until it disappeared. Whereas starting caudally, if it's normal, if it's present at the ilial wing, then we're done. We do have to, track it cranially until we lose that reflex. And it's really, really accurate in determining the actual lesion localization, in that the lesion of question is typically 2 disc spaces cranial to the cutoff. So if we have a very traditional T13L1 disc herniation, our cutaneous trunci will, repeatedly end at around L2-3. Again, we would never use that as a diagnostic to consider going to surgery, but it's remarkable how accurate that is. So again, in an effort of trying to increase efficiency for this, pretty rapid in-hospital neurologic patient that comes in on emergency, when you're doing that cutaneous trunci, start at the ilial wing and then work your way cranial. It also means you don't have to pinch them a bunch of times that they feel. So once they feel it, you're done. And lastly, if necessary, pain sensation. So I don't personally put a huge differentiation between superficial and deep pain. Pain is pain for the most part, in my opinion. The key for pain sensation is, number one, do you need to test for it? So if we have, again, a paraparetic animal, meaning they have weakness, but still have motor, then it's not necessary to test for pain. We know they have it. But if we have that true plegic animal and we need to know if they have pain sensation to help with prognosis, then we must indeed create a pretty noxious stimuli to create an active, deliberate, repeatable response. It's very common that people will sometimes mistaken a withdrawal, which is a normal spinal reflex, for actual pain. So for pain to be true, the animal must react to what you're doing mentally. So they would have to look at you, try to bite you, growl at you, whimper, do something other than just pull the limb away as we're pinching their tail or pinching their toes to determine if that pain response is true or not. Again, it seems a little unkind, but it really is important to differentiate if pain is truly present or not as we work on moving towards the next steps, which is figuring out if an animal is a good candidate for surgery or not. All right, so now that we have essentially all the information that we need to localize the lesion, we've done our cursory exam, we've done our hands-on exam, we're ready to localize the lesion. We need to figure out how we want to present it in a organized, thoughtful fashion. And so when discussing a patient, as always, we start with the signalment. I like to then mention the ambulatory status, then the lesion localization, and then the pain status if applicable. So for example, we have a 3-year-old neutered male dachshund, non-ambulatory paraparetic, localized to T3L3. That would be probably 80% of the down dogs that come into your hospital will match that sentence. So again, note that I didn't mention pain status because I said the animal was paraparetic, meaning they were only weak and they had motor present. So it wasn't necessary to say deep pain positive or deep pain negative in that sense. So a couple of more examples. A 2-year-old female spayed Shih Tzu, non-ambulatory tetraplegic, that is deep pain positive, localizes to C1, C5. So again, in this instance, the animal is non-ambulatory tetraplegic. So again, that is a little bit redundant, but again, weigh your pros and your cons there. Tetraplegic will work just fine. Pain sensation is important for the plegic animal. This animal does have pain, and they localize to C1, C5. And a 10-year-old male German Shepherd, non-ambulatory paraplegic. Again, paraplegic and non-ambulatory are a little redundant there, but it's okay. Deep pain negative localizes to L4S1. And then finally, 5-year-old female spayed dachshund, ambulatory paraparetic, localizes to T3L3. So just some examples as we're working through the terminology for these guys and trying to create a efficient way to give a colleague or give a surgeon or a neurologist a pretty concise information that they truly need. All right, so that's kind of our overview of a neurologic exam and lesion localization. And then we just have this, single slide more or less on some of the differentials for, a down dog. So again, the top differential and the focus of tonight's talk is going to be mainly disc herniation. And remember those Hansen types, 1, 2, and others. Don't forget about trauma, spinal luxation or hit by car or acute traumatic, disc herniations. Neoplasia, unfortunately, spinal tumors can create compression that can lead to these signs. Various infectious diseases, Neospora, for example, is a organism, or other infectious diseases, inflammatory conditions, those MUEs, meningoencephalitis of unknown origin, used to be called GME or NME, lots of nomenclature changes over the past several years. Autoimmune disorders, a vascular event, degenerative, like a degenerative myelopathy, an animal with wobblers, fibrocartilaginous embolism, FCE. So, several differentials, and the list goes on and on from here, but just kind of a few of those to kind of keep in your back pocket as you're just getting through if this animal's not really fitting the bill for a disc herniation. What other differentials are out there that are diagnosed, somewhat commonly? So further into disc herniations, Hansen types. We use commonly, Hansen type 1, Hansen type 2. Hansen type 3 is not really a term anymore, but we'll kind of talk about that briefly. So type 1 disc is kind of the, what we all think of when we think of a down dachshund. What that means is a type 1 disc means that they have literal disc material that is herniated out of the disc into the spinal canal. A type 2 disc is a lot more tricky and a little trickier to diagnose and treat as well. Generally a little bit less of an acute presentation for these guys. This is an animal that kind of had off and on signs for a while, but what that is a chronic disc protrusion. So notice that type 1 is extrusion and type 2 is protrusion. So an extrusion meaning the material physically left the disc, whereas protrusion is more of a bulging of the disc material into the spinal canal. But if you remember, your anatomy, your annulus fibrosus is still intact in those animals. Type 3 is something that we, hear commonly in nomenclature still, but really there's kind of transitioning away from the type 3. Now they like to call it a non-compressive nucleus pulposus extrusion, which means that essentially a piece of disc has ruptured through the annulus fibrosus and traumatized the spinal cord, similar to a bullet or a punch, but there's not a big compressive component to that animal. Another term that I like to use is high velocity, low volume. Essentially, some little piece of disc gets herniated like a little bullet and literally smacks the spinal cord, but there's not actually a physical compression created from that, just focal inflammation and trauma. There are a few other Hansen types that we won't go into because they're not really important for this talk, but there's plenty of good papers on that.
Dr. Brady, we have a question.
Excellent.
Are Hansen type determinations becoming less important based on recent publications?
Yeah, so that's a again, the nomenclature is changing, so I don't have the perfect answer for you. I spent quite a bit of time at ACVS last year going down the neurologic tract to see if there was any, you know, updated information since, again, we're going to be offering those procedures again very, very soon. And really, even in the talks from all the neurologists that I went to, they're still qualifying things as Hansen types. So I don't know. I don't think that name is going to go away in terms of Hansen type 1 or type 2. But they are, again, Hansen type 3 has gone away. So perhaps they will change the name, but the underlying theme will be the same. Instead of saying a Hansen type 1, they'll say an acute disc extrusion, for example, because Hansen type 1 is too easy. But that's my theory.
Thank
Thank you
you.
for the question. So now we've got, our proposed neurologic exam completed. We got some differentials in mind. Then we need to decide, is this animal going to benefit or does it warrant considering imaging plus or minus surgery? So overall rule of thumb would be that, most any acutely neurologic or chronically neurologic patient is likely a good candidate for imaging. So if you have an animal that's acutely down, or an animal that's gone down over the past week, or if you've had an animal that's just had, these vague neurologic signs for a long time, advanced imaging is rarely a bad idea. The fruitfulness of that imaging may be, low or lacking, but the idea of imaging is rarely wrong. The tough decision comes into which modality may be best for that animal. So, would a CT be adequate? Would a CT myelogram be good? Or would an MRI be the best option? And, overall, when it comes to imaging, there's no doubt about it that MRI is the gold standard. It is the most sensitive and specific for the surgical and non-surgical disease processes. As we know, MRI is time consuming. By the time they run all their different, weighted this, flare that, stir this, it's a hour or so of anesthesia just for the imaging, and it's quite expensive. Personal example, I had a Pomeranian that needed some imaging of his neck, and just to get the exam, blood work, test films, and MRI was nearly $5,000. After my professional discount. So MRI is the gold standard, and if there's any question, you're never wrong to recommend the MRI. CT and CT with myelogram are really great options for surgical disease. So for your disc herniations, for your traumatic luxations, for your spinal fractures, and overall, they correlate with MRI findings about 85 to 90% of the time. So the CT and the CT myelogram is a much faster, imaging modality. Literally, it takes 10 seconds for them to go through the machine, and then 2 minutes for the machine to reconstruct the images, and then we're starting to get some answers. A scary thing about a CT, especially a CT myelogram, if we do have one of those tetraparetic or tetraplegic patients, and it's a small dog, and we're not sure if this is a, MUE, the new term, meningoencephalitis of unknown etiology, introducing contrast into their subarachnoid space with the myelogram can actually lead to an intense inflammatory response and cause fatal seizures. I have personally seen that in these animals that we do we suspect a cervical lesion. We do a CT myelogram, and then, we don't see a lesion. In recovery, they start having a seizure, and again, it can be fatal. So, as with everything in life, there is a risk reward for all of those things. So, keeping in mind, no one imaging modality is perfect, but again, in a down dachshund, you can say with a very, very high probability that a CT will be more than adequate to diagnose that patient and give them the help that they need. So CT or CT myelogram is often chosen in facilities that have both an MRI and a CT for specific patients, especially if a disc herniation is the top differential, especially those chondrodystrophics like our dachshunds, our bassets, and things. So, even if we do refer them to a facility with MRI, thinking they'll get an MRI, perhaps they end up getting a CT instead. So imaging is always a tough one, with MRI forever being the gold standard, I imagine. But for surgical disease, CT or CT myelogram is a very, very good option. So this is an example of a CT myelogram. We can see the vertebral body, the bright white bone, the yellow circle is essentially the spinal cord, and you can see the white line around it being the myelogram. And then, pretty normal at A1 showing, some compression. We can see that it's, there's material coming from, the right side of the screen. I don't know. I don't have the labels on this. So I don't know if that's the dog's right or left. Doesn't matter. But, some herniation coming from that right side. And then A2, kind of going back towards more normal. So that's a example of a CT myelogram. I have a few more examples later as well. Again, here's a different view, a different plane of a CT myelogram. So you can see that I know this is a myelogram because of that bright white enhancement. Hopefully you can see my mouse on the screen here, but this bright white, this is the dye, the omnipaque, and we can see the subarachnoid space, all the way down here. And then we see a defect coming through here and then back to normal. So, it's very common to lose a little bit of contrast through that cervical intumescence. Again, in an animal here, we would localize our lesion caudally, I'm sure. And, this image would be more than adequate to let us know which disc space we might need to go in to relieve that compression. This is an example of a chondrodystrophic CT with no myelogram. So those animals that are chondrodystrophic often have mineralized discs that are ruptured. And here we can see beautifully, this is normal over here, just a normal circle there. And then now we see this bright white, which again, there's no contrast here. So this is a mineralized disc that's now pressing into the spinal cord. And then this is again another sagittal view with this very bright white disc. Again, this is all, no contrast here. This is just literally the intensity of that mineralized disc that we see as it herniated into the cervical canal there. So even without contrast, especially in our chondrodystrophics, it is glaringly obvious these disc herniations on just a plain CT. So now we have, gotten our diagnosis. We've done our exam, localized the lesion, decided the animal's potentially a surgery candidate. We've got their imaging, and what kind of surgeries are we looking at for these guys? And we're not going to go into a huge amount of detail with these procedures, but just wanted an overview of some of those things. So another question coming up, how many of you have had the luxury of scrubbing into a hemilaminectomy, maybe during vet school or your additional training, or maybe you just hung out with a neurologist one day and y'all did a hemilaminectomy? More or less 50-50, so that's great. A hemilaminectomy is a beautiful, beautiful procedure. It is just instant gratification, instant satisfaction, just like pressure washing the side of your house or a piece of concrete. Once you do the surgery and you get all that disc material out of there, it's just, instant, you just feel so good about, what you've been able to do for that patient. Next one is, have you ever seen a ventral slot? So a ventral slot is the procedure we do for our cervical disc herniations. All right, so only about a quarter of you have seen a ventral slot. The other 3/4 have not. I didn't see my first ventral slot until I did my first ventral slot because literally nobody can see what's going on except for the surgeon themselves. So we're working in an extremely small area, and I've got some pictures for you later. But a ventral slot, that's a pretty pretty intense procedure. But those of you that got to see it, hopefully were able to appreciate what's going on. So a hemilaminectomy is where we actually, dissect down all the muscles, the epaxials, revealing the dorsal spinous processes and the lamina, if you will. And essentially, as we can see on this image, this is our disc space, and we literally take a high-speed burr and we drill out a rectangular window, and we drill, drill, drill. We drill until it's extremely, just literally paper thin, until we can see through the bone. And then we take a very fine little pick, and then we, remove the rest of that paper thin bone, because naturally you don't want to take a high speed burr into the spinal canal, because that would be probably catastrophic for the spinal cord. So again, another example of a CT myelogram here. So we have a pretty normal portion of the spinal cord on the left, and then we have our disc herniation on the right. So we can see that our beautiful myelogram is completely displaced, and we can see all of this disc material that is herniated into the spinal canal there. This is an example of a hemilaminectomy that I performed back in Memphis. That was most interesting because of this dural tear. So if you can see my mouse circling here, this was actually a tear in the dura. So as you can imagine, that required a pretty high, intensity, traumatic thing to happen. And over here, hopefully you can kind of see the disc space where we decompress the spine, and then up here we identified this dural tear, which was pretty surprising, and unfortunately, often a bad prognostic indicator of enough trauma was occur to tear the lining of the spinal cord called the dura. A ventral slot is where we actually go in through the ventral portion of the neck. Again, I have some pictures later. And we actually dissect, we have to move the trachea out of the way, the esophagus out of the way, dissect all the way down to the cervical bones, and then drill this tiny little window between the disc spaces where the herniation is. So we oftentimes drill in this cone-shaped fashion, as in D here, because if we create too big of a window between the two vertebrae, then we actually are at a much higher risk of creating cervical instability and possibly leading to cervical fracture if we make this, most superficial portion too big. So we'll often kind of have a smaller outer layer and drill larger as we go deeper to create this cone-shaped appearance to try to maximize our ability to access the disc in that area. This is an example of a CT myelogram of an animal with a disc herniation in the cervical spine. So this is the trachea, then our endotracheal tube in there. You can see our little rings of the trachea down here. Here we see our myelogram, and we see our myelogram go up and down. Oops. And so we can even see that's a little bit of a mineral opacity of that disc material itself. And then, this is what we're working with. So when we do our little ventral slot, this is, literally 2 millimeters wide, perhaps, and, 6 or 7 millimeters long. And we have to drill through the bone down into the canal and scoop out that disc material. Dorsal laminectomy. So sometimes if an animal has a dorsal compression or a tumor or maybe lumbosacral disease, we actually have to come in and remove the top portion of the vertebrae altogether, including the dorsal spinous process. So this image is just literally a dorsal laminectomy that we did for, it was a German Shepherd with lumbosacral stuff going on. So we approach the dorsally, remove the entire dorsal spinous process, and we can see how much of that spinal cord is exposed now. The goal here, as with all of these procedures, is to decompress the spinal cord. So that's a pretty nice image of a dorsal laminectomy that we did. Traumatic luxations, truthfully, this animal probably didn't need a CT or a myelogram to diagnose this. This probably could have been diagnosed with just a plain film radiograph and seeing that nice step defect. But anytime we have spinal trauma, we do want to make sure there's not other concurrent disease that may need to be addressed. For example, perhaps they do have a traumatic disc herniation at the luxation site or somewhere else. To break an animal's back requires an immense amount of trauma. So getting through the imaging for these guys to make sure that it is, just a luxation or just a fracture, that they don't need a concurrent hemilaminectomy or something to that effect, is really important for these guys, even though the, simple diagnosis of luxation here is easy. Perhaps they do have concurrent other problems where a CT or CT myelogram or an MRI would be invaluable to make sure that, we don't just go in and stabilize this luxation, but they actually have a disc herniation too, and we wonder why they're not getting better in 2 weeks. So that's a comment for that component. Neoplasia, cancer, unfortunately, every now and then we do get a surprise, such as here. Again, following my mouse, we can just see that there's not a lot of bone here, and the adjacent vertebrae are beautiful and normal in appearance, but this vertebrae has been completely effaced by whatever this was. I don't have a differential diagnosis. I don't have a diagnosis for you. A lot of times when we see lesions like this, we are thinking about myeloma, but we can see fibrosarcomas in this area. We can see osteosarcoma in this area. So the differential list is quite long, but this animal essentially presented for progressive neurologic signs, and he does indeed have, the tumor is pushing up on the spinal cord here, but more importantly, has completely effaced almost this entire vertebrae. So this is another, this was more just for fun. Again, I don't do brains or anything, but this was what's called a MLO tumor of a dog that, surprisingly didn't have a lot of cranial deficits, but did have this huge honking tumor on the side of its head. And we, the owners were interested, and we took him and did a CT, and, that's what we found there. So obviously this is not really a surgical candidate, but when I was looking through all my old pictures, thought y'all would find that one, interesting, if nothing else. So as we, start thinking about what procedures an animal may get, start wanting to talk to the owner about, is this animal a good candidate for surgery, anesthesia, those kinds of things. We got to start thinking about the severity of the disease process. And there are a couple of different scoring systems. I put this chart in here as a reference for you. This chart is not the more commonly used grading system. The next slide, the modified Frankel score, is what you'll see most commonly used. But this chart did have some good, prognoses information for you as you're looking for a quick reference. So the numbers are essentially reversed, where, in this animal, in this chart, a grade 5 is your plegic deep pain negative, whereas the modified Frankel score 0 is your plegic deep pain negative. So, my overall approach to many scoring systems is to not use them. So, I would never send out a, follow-up paperwork or referral paperwork just saying simply that this animal is a modified Frankel score 2. I would put that it is a, plegic animal with pain, deep pain positive, for example, because again, there are so many different scales out there for so many different things that I try to just be use the words themselves versus trying to just say, modified Frankel score 3, and then somebody has to go look up the modified Frankel score. And similar with MPLs and everything like that, I try to more describe them, a grade 2 patella luxation, meaning the patella is out, but I can put it back in, it goes back out, for example, in my physical exam description. So again, these two scores are here just for your reference. And the prognosis and surgical treatment is, fairly accurate on the larger scaling system, and we'll go through some more of the prognosis stuff here in just a second. But the overall consensus is, as you can imagine, the more severe the clinical signs, the less optimistic we are, and the more guarded the prognosis. So a paraplegic deep pain negative animal has a worse prognosis than a non-ambulatory paraparetic animal, which has a slightly worse prognosis than an ambulatory paraparetic patient. So utilizing the scoring systems, or just knowing these information, or having the chart handy for you, will help you when talking about the prognosis for your owner. So the prognosis for dogs that are, a down dog, again, classic dachshund disc herniation, prognosis overall is really good. With surgery, 90+% of these dogs recover. Now, one of the keys here that I wanted to mention to everyone is that when I talk about recovery to an owner, my discussion involves return to function. So I let the owners know that the goal of surgery is for this animal to be self-sufficient and pain-free. They may still have a permanent deficit. They may still walk a little wonky. They may have a hitch in their giddy up, but the goal is for them to be self-sufficient and pain-free. Now, many return to normal. There's many dachshund out there running around that's had spinal surgery that you would never know the difference. But, to prep owners for a realistic expectation, I have a discussion about the expectation after surgery being return to function, not return to normality, because there are lots of dogs that may still have a little bit of a proprioceptive deficit, or may still scuff their toe when they step up on a curb. But again, my goal for all of these animals is pain-free, self-sufficient. A slight decrease in, prognosis if motor is absent, 85% is still good. Now, the big variation that you'll see in literature is, deep pain loss with, like so many things in veterinary medicine, we're becoming more and more optimistic about many disease processes, but, old school thoughts were, if they've lost pain sensation, they don't have a chance at all, almost less than 20% in some studies. There was one study that, loss of deep pain, and still 80% of those animals return to function. So with such a broad range of literature and lots of more information coming down the pipe, I still go with a classic cop out of, if they've lost deep pain, if they've lost deep pain perception, then I say there's a 50-50 chance that they'll recover. But if they still have pain sensation, then 85-90% recovery with surgery is still very good. Another topic of big debate is timing. When do we need to get these animals into surgery? So over the years, a lot of surgeons and neurologists have done studies to see, when these animals may need to go to surgery. And the data is actually surprisingly optimistic for animals that are delayed surgery, even up to 4 days in some studies. I do believe there may be some amount of bias present in those studies, so that, the surgeon or the neurologist can say, I don't need to come in the middle of the night to do this, or maybe I don't even need to come in this weekend to do this. I believe that ultimately the sooner the better for these guys. But I do also believe that we generally don't need to come in the middle of the night. During my training, we had a down animal, we would, kind of contact everyone and say, we'll be at the hospital at 8 o'clock and we'll do the surgery 8 o'clock tomorrow morning, if it's, a Saturday or a Sunday, for example. So debatable in terms of the timing necessary, but you don't need to say if this dog doesn't get surgery in 24 hours, it's never going to walk again, because that's just going to really scare the owner and put them into a panic. And we do have information showing to the contrary there. So again, even in that one study I referenced, up to 4 days, not affecting the outcome in deep pain negative dogs. So keep that in mind when we're, prepping for these animals. Again, my goal is always to be as efficient as possible and get these animals seen and treated as rapidly as possible. But saying things like if they don't get surgery in 24 hours isn't going to really help anyone. So now, some of the scary things that we deal with after, disc herniation that can occur is myelomalacia, which literally translates into melting spinal cord. Anytime there's spinal cord trauma, then myelomalacia is a potential. It's something that we talk about when we are going over all the risk of surgery and things. And it's more common with the lower lumbar extrusions, so like your L3, L4 locations. Again, it's unknown if the timing of surgery is beneficial. So, again, we don't have information to prove that if we go ahead and get them into surgery within 12 hours or 24 hours, their chances of myelomalacia are less. And there's some people that would argue that, perhaps a slight delay would prevent an undue surgery and undue cost to the owner. For example, if this animal was going to develop myelomalacia either way, but we couldn't get him into surgery for a day or two, but then we noticed those progressive signs of myelomalacia, perhaps that animal is no longer a candidate for surgery. Maybe perhaps saving the animal an undue procedure, saving the owner an undue expense. So that's a very debatable discussion in terms of, again, the timing for surgery in these patients, because the theory is that once that severe inflammatory cascade starts, there's nothing we're going to do to stop it. So that's a hot topic, if you will. Generally, there are rapidly progressive clinical signs involving, they come into you and, you see them and they have motor. By the time they get to me, they don't have motor. And then by the next morning, they don't have pain sensation and they have flaccid paralysis. So, these signs are typically quite progressive and pretty rapidly progressive at that. And so ultimately what happens, they normally have an ascending and descending component where the melting, if you will, goes caudal and it goes cranial. So this is where testing that cutaneous trunci is actually critically important in the postoperative or perioperative period. So for example, if they present and their trunci cuts off at L2 or 3, and then we hospitalize them, and next morning it's at T13, and then we're getting them into surgery that afternoon, and now it's at T11. That's a very scary indicator that myelomalacia is occurring. So the only definitive way to get a diagnosis is necropsy, and I pretty much never say never to anything, but pretty much it's always fatal. So almost always fatal for these patients. So let's see. All right, so that's my little hairy scary blurb on kind of the scariest thing that can happen, even if we do everything right. You diagnose them, you get them referred, they get surgery in a rapid way. Myelomalacia can still happen. All right, so what to expect post-op? So as kind of described earlier, the more severe, the longer to return to ambulation, with average being about 1 to 2 weeks after surgery before they're ambulating on their own again. Still at that point, some of those animals may require some support, especially getting up. But by that point, generally, a lot of these guys are ambulating very well on their own. Depending on the severity, we might have to talk to the owner about bladder care and bladder expression. So again, remembering that order of loss and order of return. So if we have that pelagic animal, then maybe they can't control or empty their bladder in a nice way. So, post-operatively, I will administer acepromazine to these guys. I find that more helpful than, just other calming medications. Diazepam's a great option, but then you got to deal with the fact that it's controlled and, diversion and all that stuff. So generally, I'll stick with acepromazine by mouth, giving that an hour or two before, you know, the owner is trying to express the bladder. Physical therapy is critically important to helping maintain muscle flexibility and tone. And a formal rehabilitation program is invaluable for these guys, but unfortunately not really readily available in our area at this time. We hope that in the coming years that'll change, but for now it's really a lot of at-home, self-help through the owners requires, a pretty thorough, discharge instructions and references to YouTube videos and things like that. So, what are some of the worst case scenarios? Again, myelomalacia being the worst. The animal that doesn't recover, even though we expected them to, maybe they need a wheelchair and chronic bladder management. Overall, fecal incontinence isn't something that becomes a big issue as long as the owner is able to, help them maintain good cleanliness. So, overall, the feces, it'll come, the gastrocolic reflex is still present and they'll, have a bowel movement. They won't know what's happening, but, cleanliness is really important. Unfortunately, there is always a risk that they, herniate at another site, or maybe they even herniate more disc at the same site. When we have to do multiple hemilaminectomies adjacent to each other, the increase of fracture is possible, or other causes of compression. They develop a hematoma, or they develop inflammation, or those kinds of things can lead to relapse of clinical signs and maybe a need for another surgery. So who doesn't need surgery? Overall, animals that present to you that are just painful with no neurologic deficits are a very good candidate for traditional pain management, such as anti-inflammatories, gabapentin, trazodone, diazepam, other muscle relaxants. The lower the Frankel score, the less chance of recovery. But again, non-ambulatory paraparetic pets may still recover 30 to 40% of the time without surgery. So there is a chance that, if an animal if a owner just can't consider surgery, there's still a chance that some of these animals, even with pretty severe Frankel scores, might recover in time. And then, lastly, the reality is any owner that is willing and able to manage a special needs pet, may be okay without surgery. Definitely wouldn't advocate for somebody to, put their animal in a wheelchair and, not even consider, surgical correction. But if for an animal and that pet owner and the right owner, if they're really able to, manage the patient well at home, they're willing to get a wheelchair and deal with urine incontinence and deal with, excellent husbandry at home, those are special owners and they can give them a chance. So as we're starting to wrap up here, kind of the things we've gone through so far are lesion localization and severity, focusing on the differential disc herniation for this talk, but, listing several others to keep in your old memory bank, talking about some of the pros and cons of imaging, and, should an animal be considered a surgical candidate or not? And then, lastly, treatment plans and kind of what to expect, after surgery. So as we start working on, let's say you want to consider a referral for one of these patients, Points East Veterinary Specialty Hospital here in Wilson, we offer CTs and plus or minus myelograms. I'm very comfortable with disc herniations, spinal surgery, luxations. I've even removed several tumors from spinal canals. We did not have a neurologist in Memphis where I trained, and there wasn't a neurologist for 5-6 hours around us. So I became very comfortable with neurologic surgery. Of course, in some of those cases, a referral to a neurologist may be the best. So keep in mind the vet school, Blue Pearl Carey, TVRH has neurologist and MRI capabilities as well. So, especially if you think they're a cranial disease pet or an MUE pet, or, there's plenty of surgical diseases that I don't do. But, always, if you're interested in sending them over to us, give us a call and we'll be 100% honest with you. Things like wobblers, I don't do Great Danes and Dobermans that are wobblers. I was never trained in that. So getting them to a neurologist would be the best for them. Lumbosacral disease, it's generally best for an MRI to get a full extent of foraminal stenosis, canal stenosis. Is there inflammation around the nerve roots in that area? So I've done lumbosacral disease before for patients that couldn't go get an MRI, but gold standard would be MRI for those guys. And of course, they're excellent at disc herniation treatments too. So never a bad thing to get a neurologic patient to a neurologist. So, but for those patients that maybe can't quite afford that or don't want to travel so far when it comes to a lot of these neurologic conditions that are surgical in nature, I thoroughly enjoy neurosurgery myself. When you're doing a referral, keeping in mind kind of the basics of a good referral, direct communication if possible. So being able to contact, and talk doctor to doctor is always invaluable to make sure we can get all the information that we need. Screening radiographs for these guys is always excellent to do just to rule out things like trauma. By far and away, the screening rads will be unremarkable, but maybe you do pick up that this down dachshund actually might have gotten kicked by a horse in the yard and has a spinal luxation, for example. Getting back to that, efficient communication with the signalment, ambulatory status, plegic versus paretic, your lesion localization, blood work and radiographs, and of course, be ready to go over in detail your neurologic exam because perhaps the person taking the phone call, especially if we're talking to an intern or a resident or someone at NC State, they may have a whole list of questions for you. So being ready to go over your thorough neurologic assessment will be really helpful to get the owner the best information that they can. By far and away, most of these animals will come through the ER and they get transferred to surgery or neurology for imaging plus minus surgery. Ideally, they would get imaging straight to surgery if that's possible. But in some situations, and even in some vet schools like Mississippi State, back in the day, they had a completely different imaging center. So they had to take these down dachshunds down to a different center and do their CT down there or MRI and then wake them up, get them back to the vet school and then do surgery later that day or do surgery the next day. So, but by far and away, most folks are able to go straight from imaging to surgery if indicated. Generally, they're going to spend 2 to 3 days in the hospital after surgery, pending severity and how much recumbency care the animal may need. 2-week recheck for incision check, standard stuff there, and then I like to see all these guys back in about a month to see how they're doing. And by that point, my hope and my expectation is that they are fully ambulatory and self-sufficient and comfortable. And after that first couple of weeks, most of these animals are doing really excellent. Maybe a little hitch in the giddy up, but again, pain-free and self-sufficient. When referral is not an option, communicate the reality with the owner. Are they really able to handle, this kind of animal that's maybe plegic and needs recumbency care, bladder care, husbandry. And it's okay to put a timeline on it. So if this owner says, I can't do this forever, but I can do it for 2 weeks, that's okay. Again, there's not a magic number here. And, 20, 30, 40, 50% of these animals will return to ambulation, even without surgery. So that's always a consideration, and humane euthanasia is okay. Nobody wants to euthanize a healthy 3-year-old dachshund that's acutely paraplegic, but the reality is, that's going to be the best thing for them and the family and the situation that sometimes, and that's okay. At home care, we're kind of refocusing here on bladder care and expression. And, for those animals that can't get surgery, talking to the owner about, how often to manage the bladder, ideally every 4 to 6 hours. But if not, then they can push it to 8, maybe even 10. Maybe that animal is used to holding their bladder 12 hours. And that's okay. Most pets are still able to reposition themselves while folks are at work. So, you can't, every animal is different and every situation is special. Cleanliness oftentimes involves, little gentle running water. we want to avoid friction for these guys. These animals might have to get cleaned several times a day. So, aggressive rubbing and friction will just further exacerbate those problems. So, rinsing them with nice cool water and patting dry. Again, acepromazine before bladder expression or diazepam. And then pain control, again, the traditional anti-inflammatory of choice, gabapentin, amantadine. Remember, amantadine does take a couple of weeks to achieve therapeutic levels. Acepromazine for calming or bladder expression, trazodone for calming, to help relax these patients. Because some of them are they don't know what's going on. They can't use their legs and they can be a little, rowdy. So that is it for my presentation there. So see a couple of things in the chat, but I'll go ahead and mention that Dr. Saker will be doing our next discussion. It'll be April 30th at 7 p.m. talking about updates from nutrition department, bridging nutrition into the treatments and plans. So that'll be our next discussion at the end of April. So let's open it back up to questions.
So we do have a few questions. Okay. Thoughts on I can never say this, bethanediol.
I've never used it personally. Bethanechol, is that?
Bethanediol, thank you.
Okay. Yeah. I've never used bethanechol personally. But the reality is I don't know if, the pharmacokinetics and dynamics of it and the actual receptors within the bladder and things, it doesn't really fit. I think ultimately we're going to find out it's kind of like prazosin and blot cats, probably not really useful. But again, I don't have a lot of personal experience with that one.
Okay. A couple people kind of asked this theme. So NSAID versus steroid for initial anti-inflammatory therapy.
Yeah, that's a great question. And I thought about adding a slide to it, but I figured somebody would ask it and it would at least force a question or two out of the audience. So the long and short of it is I've never heard a neurologist have a strong preference. Some of you may have, and that's okay. But generally, all the talks I've gone to for neurology specific things, talking to neurologists in general, they all say whatever is okay. I do believe that steroids have better anti-inflammatory properties than an NSAID. And what I mean by that is I've seen many animals not respond to traditional NSAIDs that did respond to steroids. For example, an animal with just back pain or neck pain that non-responsive to NSAIDs and such, and then we either do a short washout period or we transition them pretty rapidly, but utilizing gastroprotectants and things. And then they do respond to, an anti-inflammatory dose of a steroid, 1 to 2 mg per kg. So I do believe that steroids overall are going to help with that inflammation better. And if I had to choose in a potentially life or death situation, I would send no. If that animal is just, they can't do surgery, we're going to try some medical management. I would do steroids in those patients because I do believe that steroids have a stronger anti-inflammatory effect than NSAIDs.
What about it's Friday afternoon? Maybe they're going to think about it over the weekend, but maybe it would end up having surgery on Monday. Would you want them to go home for the weekend with?
It would not bother me if an animal came to me on steroids.
Okay.
And most of the neurologists at the talks I've gone to have said the same thing.
Okay. This one's for methylcarbamol. Use it with lesion cases or paresthesia cases. Like, how do you feel about methylcarbamol being used?
Yeah, so methylcarbamol, I've never been impressed with methylcarbamol. I've never really liked it as a drug, and I've never really had a lot of what I felt was a perceived true benefit of using it. However, if we're going to utilize it, I wouldn't have any problem with all the levels in terms of Is it just a back pain animal? Methocarbamol is not going to hurt. It may not help, but it's not going to hurt. Paraparetic, maybe they're having muscle spasms. Maybe it'll help. Definitely not going to hurt. Paraplegic, same thing. So methocarbamol dosing, generally I do go towards the higher end of that dosing, close to 44 mg per kg. If I were to use it, because I haven't perceived a lot of benefit of it in the past, and I've never sent it home after surgery for patients. Traditionally, after surgery, it's just whatever anti-inflammatory they were already on, if they were started on one, and then the gabapentin and the calming medication of choice. Again, acepromazine if this animal is going to need some bladder expression, but methocarbamol. I've been prescribed methocarbamol for my old man back problems, and I've personally never had any benefit from it either. So I'm skeptical.
Okay. Next question. Have you seen osteomyelitis of the vertebrae create neurodeficits?
Yes. Discospondylitis, is another, essentially osteomyelitis of the vertebral end plates. And yes, I have seen those lesions create neurologic deficits, especially in our larger breed dogs. If you remember, discospondylitis is best treated with 6 weeks of 22 mg per kg PO cephalexin Q12. But yes, and that's something that we can pick up, both on CT and MRI, those changes consistent with osteomyelitis.
What did you recommend a trazodone dose for these guys?
So overall, the same as any other patient, between 5 and 10 mg per kg every 8 to 12 hours. And reported dose ranges go up from there, even up to 17 and 19. I try not to go much above 10 because that's the basic recommendation is 5 to 10. But if it goes over to 11 or 12 to fit the animal's weight a little bit better, it doesn't bother me.
Okay, there's a lot about, you're right, there's a lot about steroids and NSAIDs, so I think you have answered that. In a quick overview, what is done to fix a vertebral lux?
A vertebral luxation?
Yeah.
So if it's strictly a vertebral luxation and there's no fracture, we can approach it many ways. We can utilize internal fixation, or we can utilize external fixation. So essentially, we dissect down to the location of interest, as well as several vertebrae, cranial and caudal, to the lesion, and we utilize whatever we're going to use. Oftentimes, internal fixation is chosen because it's less maintenance for the owner, and nobody likes to see a external fixator, poking out of their dog's back. But it is actually really, really. I've used that in the LS region because the wings of the ilium get in the way trying to utilize internal fixation, because the wings of the ilium literally block the vertebrae where you would want to put in the plate, for example. But we dissect down to the location of interest, several vertebrae, 2 or 3 cranial and caudal. So it is a big approach. We literally, put in, either the cranial or caudal components of our fixation device, either on one side of the vertebrae or both sides. So sometimes they get a plate on either side of the dorsal spinous process. Depending on the region of location, we have to remember our angle of screw insertion to avoid the spinal canal. Generally, it's around 30 to 45 degrees, depending on whether we're mid-thoracic, lumbar, thoracolumbar. And essentially, kind of have an assistant hold the vertebrae back in place, so reduce it, and then fixate the plate in front of and caudal to the luxation. So if you remember any of your orthopedics, kind of creating almost like a bridging fixation for a tibia fracture, where we put a couple of screws at the top. There's a big convoluted mess in the middle, then a couple of screws in the bottom. A similar approach to the luxations, and you can utilize again an external fixator device to do the same thing, or specifically, oftentimes a string of pearl plate is what's used because of its very pliable nature, we can bend it in multiple planes.
Interesting, thank you. Another question, should the treatment in the short term be changed if a patient can't have same-day imaging, such as like, will an anti-inflammatory medication impact CT/CT myelogram results?
No, no. So, you know, I would never withhold palliative care, you know, whether they might get imaging that same day or not. You know, I would go ahead and, you know, in your hospital, if they're going to be there, you know, Rimadyl injection is fine, or, you know, a steroid injection is fine, or, you know, giving them the oral, say you're going to send them with, all that is fine. Or if nothing else, you know, if you're worried about that, you can always try to do a pure mu injection, you know, while they're getting transported to the referral center, you know, a hydro, or a, even if you just have morphine or methadone, or you know, fentanyl is very short acting, so probably not the best option. But if you do have concerns, or maybe you do have a relationship with a neurologist somewhere and they're a little bit more finicky than some, then, you know, if you have that ability to give them a relatively mid to long acting pure mu, that would be a good option.
Sure. I think this is summarizing what you've already mentioned, but it is a good summary. What does the post-op period look like for an animal that has gone through back surgery?
Yes. So post-operatively, they generally will be in the hospital for 2 to 3 days, and that's mainly for recumbency care in the hospital to try to give the owners a jump start. Because naturally, these animals are infinitely more comfortable the second we decompress the spine, similar to a fracture repair. As you imagine, if you had something pressing on your spinal cord and we took it away, you'd probably be a lot more comfortable. Just like if you have a broken tibia flopping around in the breeze and we fixate it, you'll be a lot more comfortable. So after surgery, really the pain that they're dealing with is soft tissue dissection. So yes, it's uncomfortable, but you know, nowhere is intensely uncomfortable as, you know, the herniation may have been. So 2 to 3 days in the hospital, kind of figuring out how aggressive we're going to have to be with bladder management, making sure they are comfortable with the soft tissue palpation. Oftentimes, you know, they're showing improvement in neurologic signs before they're discharged, whether it's continence has returned or motor's returned, or, I mean, and some of these little petite healthy dachshunds are completely down and they're moving, you know, they're walking 2 days after surgery. So it's really, really awesome and remarkable. So post-operatively is focused mainly around getting a jump start on the physical therapy and husbandry for that patient, so that we can most accurately inform the owner of what they're going to be expected to do once they get them discharged.
This is a two-part question. Do you see a percentage of patients with a healed herniation that are predisposed to a second herniation? And then with that, do you advise owners to limit activity after full recovery due to a chance of recurrence?
So I am sure there's a publication number out there, but I don't have it on the top of my head for the chance of multiple luxations. There are studies that have looked at the number of ossified disc in dachshunds that has been a predictor of disc herniation, initial disc herniation, but I can't pull any recurrent disc herniation number off the top of my head. I'm sure there is one. And as far as recurrence, we like to say, hey, you need to make your animal lose weight so they don't do this again. But the reality is they've actually shown that there are no predictors for recurrence, in terms of they've shown that, you know, decreasing activity doesn't, you know, affect recurrence. Body condition doesn't affect recurrence. You know, up and down stairs doesn't actually affect recurrence in the studies that have been published. So really, you know, we still, you know, it just makes logical sense to recommend that this animal loses weight, or recommend that this animal doesn't jump off the couch anymore, because those are really, you know, it just makes a lot of sense that it would be true. But in literature, they've actually not shown that to be a cause and effect.
Interesting. All right. That is everything that has been entered into the chat and the Q&A. So we might be wrapping up for the evening.
Excellent.
Yeah.
So for those of you that are a little more interested, everybody can leave. Thank you so much. But I put a couple more slides in at the end. My first ventral slot was actually on my personal dog, Lincoln, who I married into, Abigail's dog when I met her. So when I said the first time I actually saw a ventral slot firsthand was on him, because you just can't see anything when you're the assistant. So this is Lincoln, getting his CT myelogram, and these are his images, seeing his little disc herniation here, and this is him, getting prepped for surgery. We make our approach on the ventral aspect of the neck there, and then, that's my hand, and just, you can see the end of my finger, and, that's how much space we're working in down there, working our way down to the actual vertebral bodies themselves. Having everything cleaned up on this side where we're actually going to make, nothing here is abnormal. So that's not like disc material herniated or anything. That's just soft tissue. Making our actual slot on this side. Then that's me and Dr. Atwood, one of the guys that trained me at Memphis Veterinary Specialist, and Dr. Graville, who was an intern at the time. Then, there's our nice, lovely closure. Then there's Lincoln, after surgery. And then, if you can see in this tiny little jar, this tiny little speck of goo was, the herniated disc material that was causing all of his problems. So, and that's a very typical dog size. So, these are really tiny procedures when we're doing most of these ventral slots on these guys, and just staring through a tiny hole like that, trying to scoop out the disc material and not traumatize the spinal cord. And unfortunately, I have heard horror stories of vertebral artery or vertebral vein hemorrhage leading to exsanguination. I haven't seen that happen, but was definitely something my mentors warned me about, because apparently they did see that happen down in Mississippi State one time. So just constantly suctioning the blood and not realizing the cumulative effect in the animal passing away. So, as with everything, there is risk, and these vertebral surgeries, hemorrhage is a risk. So, that's all I have. There's no other questions.
Many thank yous and really helpful information, comments such as that. So thank you, everybody, for attending tonight. And we hope to see you on the 30th of April. Thank you, Dr. Brady. It's always really informative and realistic for what we can do the next day at work. Thank you so much.
Thank you, everyone. Have a great night.